Okay, so let's talk a little bit about CT dose. And here's some objectives. Let me zoom in on this. So we're just going to review the basics of radiation safety, the absolute basics. What I would say are kind of the two cornerstones of how we do CT scans safely, right? We just need the basics right now. We'll define some terms related to measuring the CT dose. We're going to consider the impacts of geometry and how dose is distributed. Since we're swinging the X-ray tube around people, geometry is going to be a factor in this. We'll look at ways to compare examination doses across different exam types, and then we'll talk about the education component, because I'm going to ask you all to start to think about yourselves as teachers, and this is probably your number one lesson. So the reason I stress that it's boring, that it's overwhelming, is because this is what, I can't remember the exact percentage, but the overwhelming majority of our patients, the last time I saw surveys of patient radiation safety knowledge, the patients looked to their technologist to explain radiation safety to them. Not to their doctor, not to the ordering physician, not to the radiologist. They looked to y'all to explain how this is safe, why this is okay to be doing this, when we know that it does all sorts of weird stuff too. So we all need to start think about ourselves as educators in this regard. And then finally, we're going to look real particularly at pediatric examination, and we'll talk about what are some of the unique factors for safety around pediatric examination. Okay, and following that, I've got a brief Socratic discussion that we'll do, and then I've got some activities for us at the end. Okay, so that's our class today. So the basic dose concepts for using CT scan is that, and this is, I would say, the very first thing that we should always talk about with our patients is that there is a benefit and a risk. That's the way I frame every discussion of radiation exposure for patients, is that there's a benefit and a risk. Like, here's something to think about. We are the only sector of all the people who work with radiation who can intentionally expose the public to radiation. Nuclear power plants can't do that. The people who make your roads and things, they're using cesium-137 to do moisture analysis. They can't intentionally expose the U.S. public to radiation. We alone, of all the people who use radiation, can intentionally expose the public to radiation. Why do we do it? Well, there's a benefit to it, but we also need to say there's a risk. So that's the framework that we always need to give people. Let's talk about the benefits. Let's also talk about the risks. In terms of understanding how these benefits and risks all break down, we need to be able to see, is this the appropriate patient/exam? So we'll call that justification. Can I justify why we're doing it, and why are we doing it to this patient, right? And then the other part we've already kind of mentioned is optimization. And this means that we're going to minimize the radiation dose without compromising image quality. There's a balance there of minimizing dose without compromising image quality. So those are kind of the three cornerstones that I would give you for communicating about this stuff. Number one, for the patient, I'm going to explain there's benefits and risks to this. And one of the first things that I look at is whether or not we should be doing this exam. We call that justification. Right? If we determine that this is the appropriate exam for this diagnosis for you, now I'm going to look at how can I optimize my radiation dose to keep it as small as possible while still getting good pictures. And that's pretty much the way I educate patients. What I just said there is the way I've educated a lot of patients. It provides the foundation for any other question the patient might have. So let's talk a little bit about terminology, and this unfortunately is where things can start to get a little confusing, and she even manages in this textbook to make this part a little bit confusing, so I'm going to try to simplify this as much as possible. The units of exposure in air, right, are either Rankine or Coulomb per kilogram. So Rankine is what we would call the traditional unit, and Coulomb per kilogram is the SI unit. Both of these are measuring the amount of energy that's just created in a certain volume of air. So Coulomb per kilogram literally has it right there in the unit that this is an amount of energy, a coulomb, that's produced in a kilogram of air. If you want to know about how big a kilogram of air is, in X-ray we use a 40-inch SID a lot. That's roughly, if you had a 40-inch SID square, that's about a kilogram of air. Okay? And so there's no patient in this. There's just X-rays and air, right? Or even alpha particles and beta particles in air. And they are producing electrical sparks. They're producing a charge in the air. And we will call that exposure. So that term is very, very specific. I can't stress that enough. That when we're talking about exposure, we are just talking about ionizations in air. Okay, moving along, now we need to think about an absorbed dose, or what the patient received, right? I'm going to altogether get rid of the RAD. The RAD is dead, right? The ART made that determination last year. You will still see it some in the literature. It is a traditional unit of radiation absorbed dose. That RAD was an acronym for that. But it is dead. In its place, we have the gray. Now, why do we have the gray in the place of the RAD? This is a really good question, and so I want to clear up one possible point of confusion that she doesn't really clearly address in this chapter. So we've said that the coulomb per kilogram is going to be an exposure. A gray also equals a joule per kilogram. So it is directly tied to now an exposure in air, the amount of work that it's doing, right? So the one is the energy, the joule is the work that it's doing, right? The work that it's doing. So a gray is telling us what kind of work can this do. And when we're talking about something doing work, we mean that it is able to affect matter. It's able to move things around, right? So sometimes we'll put this as gray sub A, right? Gray sub A is, again, an exposure expression, because we've said this is the amount of work that it's doing in a volume of air. Gray sub A, the A means air, right? Conversely, we can use gray this way. We can say gray sub T. Now it's the same thing. It's still joules per kilogram, but we're saying now it's hitting the patient. Now it's hitting the patient, and as it hits the patient, we're going to start to call that a dose. So we started out with an exposure in air. Once the patient gets involved or a worker gets involved, any biological system gets involved, we start to call that a dose. So the gray is going to be our unit of absorbed dose. It is just saying this amount of exposure equates to this amount of dose in tissue. And we have ways that we can convert it and stuff. Okay? Moving along, and this is probably the part that she confuses the most. So you can go ahead and top of page 166, she starts to talk about a quality factor. Just X that out. All that discussion of quality factor is not very helpful. What she's trying to address is what I would call weighting factors. A weighting factor. And this has become the predominant use in the literature is we have W sub R and W sub T. So W sub R is the weighting factor for the radiation, which the good news is in CT and X-ray is 1. It's 1, period, done. It's also 1 for gamma rays, but it is not 1 for alpha particles or beta particles. They get a weighting factor that's higher. And we'll talk about why that is later on, like in the fall. But for right now, just know that the weighting factor for the radiation we use in CT is 1. So you don't even really have to account for it, right? Because what you're doing is multiplying this stuff together. The weighting factor for tissue, though, is where things get confusing, right? And some physicists would even say that it's not even appropriate to talk to patients about any kind of effective dose. We can only be talking to them about an absorbed dose because we do not calculate how this stuff is actually affecting their body. To do that kind of a calculation, we need a weighting factor for the tissue. Because every single tissue system, every single organ system in your body responds differently to radiation. Every single organ system in your body responds differently to radiation. So, for example, we're more concerned with someone's eyes than we are with their femur, right? we're more concerned with like the gonads or something than we are with bone or fatty tissue. So we have to weight that appropriately. And so this is the way that we break down the weights for radiation exposure. So there's people who get paid big bucks to sit around and actually figure out what was, for example, a fetal dose, or what was the dose to the patient's lungs, or what was the dose to this worker's eyes, right? Keeping in mind all of these weighting factors. We do not, fortunately, the good news is you don't have to do that, right? That is not part of your job description. So the reason I'm mentioning this to you is because you need to understand dose gets fairly complex fairly quickly. So in terms of addressing this with the patient, focus on benefits and risks, right? Focus on keeping this simple and understandable. But for you yourself, you need to understand it's different if I'm irradiating someone's abdomen than if I'm irradiating their head. That's the big takeaway from this. And so we'll look at some differences as we move forward. But for the purposes of calculation here, or at least being able to think about this, we will use these weighting factors to account for different types of ionizing radiation as well as different types of the body, different areas of the body that are exposed. And from that, we can calculate an effective dose. Anytime we're talking about an effective dose, this is where we came up with the term sievert. So sievert takes into account not just the radiation exposure in air, not just the tissue dose, but it's going to multiply those both by weighting factors for the radiation and the tissue that was exposed to come up with the sievert. So the sievert attempts to account for the effects of the dose all throughout as it's distributed all throughout the patient's body. It is the most complicated of them all, right? And so the way that we do that is we take the dose in gray, we multiply it by the weighting factor for the radiation, multiply that by the weighting factor for the tissue, and then we get an effective dose. There should be a dose right here, sorry. Don't get too bogged down in that right now. I just want you to understand that the big distinction is here is we have some terms related to exposure, some terms related to dose, and then we have some terms related to effective dose. And each one of those, exposure, dose, effective dose, are very specific language, only related to certain kinds of ways to measure this stuff. Okay, so let's change gears just a little bit and talk about the geometry of this thing. So we've mentioned that we're swinging an X-ray tube around a person's body while we're exposing them to radiation. So the dose is going to be distributed strangely, right? And we will expect it to do things differently than, for example, the dose from radiation therapy or nuclear medicine or even general X-ray. So the uniformity of the dose decreases as the scan field of view and the patient body increase. So the way that this dose is distributed is going to become much stranger as we get a smaller field of view and a larger patient's body. Body scans are less uniform than head scans. That's probably the easiest way to remember this, is that body scans are less uniform than head scans. Why would that be the case? Well, if you think about like a body, the way a CT scanner thinks about a body, it looks kind of funny. It has an elliptical shape. So this is the way a CT scanner sees your body. It's swinging an X-ray tube around that, right? And so any radiation that comes from this side is going to do something a little bit different than any radiation that comes from this side. It has less tissue to go through, right? So we would expect it to be less uniform in its dose distribution, if you're tracking with me. Versus if we're thinking about a head, it's fairly, I just drew a terrible picture of a head, but it's fairly uniformly a circle, right? So if this is illustrated on page 167, much better in our textbook, but you can see the elliptical shape of a transaxial slice of the patient's body is going to result with an increased dose at the patient's a kind of superficial level, so there'll be an increased superficial dose and less of a dose towards the center of the patient's body because more attenuation has occurred there. Versus with the head, the dose is pretty uniformly distributed throughout the area that's being scanned. Okay? As a general rule of thumb, the central dose of a body scan is approximately 1/3 to 1/2 of the peripheral dose. So it's the periphery that's getting the majority of the dose. And that makes sense, right? That makes sense when we think about things like half-value layer and attenuation and stuff. As these photons travel through the patient's body, more and more energy is being attenuated until it gets to the center. It's not going to have as much energy as it did at the edge. So there's going to be more dose out there towards the edge. So this accounts for a really, really critical thing to think about. Organ doses are going to be higher for kids, right? Compared to large adults. It's kind of counterintuitive. You would think the fat man is getting more dose than the kid. The kid is getting more dose than the fat man because of the way this geometry works. Okay? So there's going to be more of a dose to the patient's organ because there's less to attenuate. Basically, the adipose tissue is almost working as a lead shield. It's working as a shield to vital organs. There is also additionally, so that's kind of what we just talked about was dose in that X and Y coordinate. There's also going to be funny things that happen with dose along the Z-axis, right? And so if you look again on page 167, it has it illustrated very nicely in that if we're traveling along the Z-axis, the radiation is going to kind of tail from one slice to the next. So what I've drawn here is the Z-axis. Let's say this is the slice that's defined by the collimator, right? The dose is actually going to do something like this, where it tails kind of from one slice to the next. So what happens as I get more slices in here, we start to see this tailing effect overlap from one slice to the next, and we get these little hot spots where that tailing effect has created scatter radiation that's increased patient dose from slice to slice. So it is, again, not uniform along the Z-axis. Because of scatter and other things that are going on, we are getting tails which contribute to approximately 25 to 40% of the total dose. It's created by this tailing phenomenon. There's no way to avoid it. This is just basic physics. So considering that, we're going to switch gears again now, and we're going to talk about some terminology that's used specifically to talk about dose from the CT geometry point of view, right? The first is this multiple scan average dose. Of all the stuff that I'm talking about today, this is probably the least important part. But basically, it's saying that this is the way that the physicists arrive at some of these other terms. They do a series of scans over and over and over again on a phantom, and they average that material together. They average those numbers together. That is not done on patients. That is done on phantoms, right? But then out of that MSAD, they are going to say, this is an appropriate CTDI for this area that you're scanning. So that MSAD is put into the computer, and the computer knows that anytime we're scanning this amount at this energy, this is about what the dose index is. So it's part of constructing that dose index. This is reported by CT manufacturers to the FDA, and the FDA says, okay, that's good or not good or whatever, right? The slices have to be contiguous, so the pitch has to be 1 for the reason that we just talked about, that there is this tailing effect. So if I'm changing the pitch, I need to be aware that different manufacturers, that CTDI number may or may not change. Because, again, it was calculated solely for a pitch of 1. So the machine may not be that smart. It may not be able to make that shift with me. This led to a need for a way to weight this thing, both in terms of scan geometry as well as the patient. So that's the CTDI weighted average, or CTDI sub W. You'll see that sometimes out there in the literature. But generally from that weighted average, let me page along, what we're driving at is this CTDI volumetric, right? It's kind of the gold standard right now in terms of reporting or a way to compare dose between different CT examinations, different manufacturers. The volumetric is going to account for this exposure variation along the z-axis. It's going to measure the exposure per slice, independent of scan length, and it has become the preferred expression of radiation dose in CT. So right now what I'm saying is CTDI volumetric is kind of the gold standard. It's the one to be aware of, the one to understand. Prior to initiating any CT scan, any CT examination, the CT scanner has to tell you this is the projected CTDI for this exam. It will project it. It will say, this is what I anticipate the CTDI will be for this exam. It's a weighted average. Is it 100% accurate? No, it's not. It's just a weighted average. The DLP is going to tell us what this dose looks like distributed over the length of the entire exam. So it's going to take the CTDI volumetric, which is an average, and it's going to apply that average to the entire length of the exam. So it will be a bigger number because it's multiplying the average by the distance. So again, it's a dose length product. I think that's the easiest way to remember what it's doing. It's taking the average dose and multiplying it by the length of the CT scan, the amount of travel along the z-axis. So this is the way that we are able to compare CT dose, is looking at these numbers. Are they perfect? No, and we'll talk about why they're not perfect at a later date. I just want us to make sure we have this groundwork terminology that we can all kind of share. But the big takeaway here in terms of dose comparison and what we've learned from doing these comparisons is CT is significantly higher than X-ray. So anytime I'm explaining the risks of CT examination to a patient, or why we might be doing a chest X-ray versus a chest CT, the dose for the CT scan is approximately 100 times higher. I'll say that again. The dose from the CT scan is like 100 times higher. Okay? The reason I'm repeating that is because in a recent survey of ER physicians, radiologists, and radiographers, they did not know that. She talks about that in this text later on. She makes it a little bit confusing, but we'll look at that in just a minute and try to talk about why this is a concern here. So the average absorbed dose is about 100 times higher. So the benefit, what on earth could be the benefit related to that risk? Well, this higher dose is the price that we pay for excellent low contrast resolution, for increased sensitivity, right? We've talked about how low contrast resolution, sensitivity can be used interchangeably. The way I'll talk about it with the patient is I'll say, this exam has an increased sensitivity for what we're looking for. So it is helpful for, in terms of this discussion and educating our patients, the very next step I will say is, did you know that there is natural background radiation? Every day of our life we're being exposed to some kind of radiation, even as we're sitting here talking, right? Radiation is a natural part of the Earth's atmosphere, and we're exposed to a certain amount of it every day. So knowing that, the average background radiation for most Americans is about 3 millisieverts. Right? They averaged it out across the entire population so that every year we're exposed to about 3 millisieverts of radiation from cosmic rays or radon or whatever that's in the Earth's atmosphere. The exposure from the chest X-ray, by comparison, is like 0.1 millisieverts. So if I was going to continue with the year analogy, every year we're exposed to 3 millisieverts. That means a chest X-ray is like 2 weeks of what you naturally get. A chest x-ray is about 2 weeks of natural background radiation exposure, just by comparison, right? But the exposure from the chest, abdomen, or pelvis CT is like 10 millisieverts. So it's closer to 2 years of natural background exposure. And that's exactly how I explain it to the patients as I talk about, look, there is natural radiation that we are exposed to every day of our lives. Certain exams are like 2 weeks of exposure, like an x-ray would be 2 weeks of exposure. A CT scan is more like 2 years of exposure. And this is the best way for them to understand the amounts of radiation that we're talking about without me having to say, okay, now first of all we need to explain exposure and what Rankins are, and here's a gray in air and a volume of air. No, you'll just lose them. They've already got enough stress. Don't trouble them with that. Another way to potentially talk about this is air travel. This tends to put people at rest because most people would love to take a trip to Paris, right? So you can say a chest x-ray is like a trip to Paris. It's the same amount of exposure that you're getting from cosmic rays when you go up in an airplane. In fact, airplane pilots have the highest occupational radiation exposure of anyone working in the United States of America, and we don't monitor it. So there's something to think about right there. Yeah, it's a weird thing. So the trip to Paris is like a chest x-ray. 100 trips to Paris is like the chest CT, right? Again, just to put it in a context that the patients understand. You're saying that's terrible because you worked in the flight industry, didn't you?
I did, and
Yeah.
my mother still does. She's a flight attendant.
Yeah, so
She gets a lot.
yes, yeah, they do, and they don't monitor it. Again, it's just a small portion of the overall population. So let's change gears again and talk about specific factors of CT scanning that affect dose. We've talked about radiation beam geometry. We've mentioned that filtration in previous discussions will help us improve the quality of the beam, and it's also going to reduce patient's surface dose. So filtration is going to reduce like skin dose. It's just getting rid of the crappy x-rays that we're just going to hit the patient's skin, ionize the skin, and be done, right? Detector efficiency. As detector efficiency increases, we will see increased sensitivity to x-ray. So again, the more efficient the x-ray detector is, we'll see a decrease in dose overall, right? And this is the drive for better and better scanner hardware, but we've pretty much hit the hardware wall. Like, I don't think we can progress too much further in like crystal construction or the way that these detectors work. Slice width and spacing. We've talked about how pitch has an impact on patient dose. So this is related to slice width and spacing also, that as we have smaller slices, and they're spaced closer and closer together, we would expect as these slice widths and spacing decrease, we would expect to see dose increase. As the slice width decreases, dose would increase. Pitch also has the same kind of inverse, let me think, does it have a? Yes, it has the same kind of inverse relationship. So as the pitch decreases, the dose increases because we're moving less far as we're scanning, so we would see that dose increase. And then scan field diameter is the same thing as like collimation and x-ray. As we get a bigger and bigger scan field, we will see the dose increase as well. So this is a direct relationship. As the scan field increases, we would expect the dose to increase. I know that does not even look like English, but watch the video again if you have to. I'm sorry. A couple other things to think about. Radiographic techniques, so things like mass and KVP, and we've said those are a little weird in CT, right? And what's interesting is in this chapter she actually contradicts herself. So earlier I told you to scratch out her saying something about KVP. In this chapter she gets it right. And she says that as KVP increases, radiation dose increases by approximately 30 to 45%. That's on page 171 you can star it under radiographic technique. So here she gets it right. As we increase the KVP, we are increasing patient dose in CT. As the patient size and body part thickness increases, we have a strange kind of relationship that happens. We've already talked about that a little bit. It's related to this geometry. So the larger patient is going to get less of an effective dose than the smaller patient because there's less padding around vital organs. Of course, repeat scans go without saying. We want to avoid that. We want to have collimation that's appropriate for the examination. And just, I know we're talking about things fairly abstract, so here's from the ACR, here's some dose reference values. So that's American College of Radiology. And this slide actually comes from, I think, the American Medical Physics Association. This is CTDI, volumetric, with these two reference levels that the ACR has identified. There's a reference level, so about what this should be, as well as a pass-fail level. The reason we have that pass-fail level is because certain folks are bigger than others and stuff like that. So for an adult head, we're talking about 75 milligray. It's one of the hotter exams that we do, an adult head. An adult abdomen is like 25 milligray. Conversely, if you look at the pediatric abdomen, it should be less, right? Because we're going to try to modulate the dose accordingly, but just because of their reduced size, they're still going to have a substantial dose, so closer to 20 milligray. In the pediatric head, 45 milligray. And that's a non-negotiable. That's why there's not a pass-fail there. We should not be scanning kids at adult levels. So why is this concern? So there was a report that came out from the NRCP, report number 160, and I'm trying to remember exactly when it came out, I think 2006. It compared the average U.S. radiation exposure from the 80s to the current radiation exposure, and it found a sizable increase. Natural background radiation was the same. Natural background radiation has been the same for thousands of years, about 3 millisieverts a year. What they found was a substantial increase in the usage of CT scanning. And that usage of CT scanning had now said all of this other stuff, all the artificial radiation that we're exposed to, is now equal to or a little bit greater than natural background radiation. So what I'm saying is 6 millisieverts per year is what the average U.S. citizen is exposed to every year when you take both natural background radiation and artificial radiation exposure. So flights to Paris, the road that you drove on, the smoke detector in your house, but the big one is medical imaging. CT scanning in particular had the biggest piece of the pie. And we'll look more at that report coming along, but that raised a lot of eyebrows, and we really started to reevaluate how we're doing CT scan from that point on. There's been new information that's coming out about the effects of low doses of radiation. We did not have that information before. We're starting to get it now, and we're starting to see things like I said, double-strand breaks on DNA of, I think it's either T or B cell lymphocytes. So we are interrupting white blood cell counts from CT scanning. We're decreasing white blood cell counts. There's a need for education among the people working with it. So she kind of walks us through this. I don't know that her discussion of it's super helpful. It's on page 173 in the textbook. But the big takeaway here is that the researchers concluded, Lee and his coworkers concluded, this is bottom of page 173, that patients are not given information about risks, benefits, and radiation dose for a CT scan. Patients, emergency department physicians, and radiologists alike are unable to provide accurate estimates of CT doses regardless of their experience level. That's a problem. I don't remember the exact numbers, but it was low for how many people could actually walk through with the patient, say, look, this is about the risk level that we're talking about. These are the benefits. There's been inappropriate scanning parameters found in some facilities, and we'll look at that here in just a minute. Extra images are really commonplace, and it's especially problematic in CT where they'll say, okay, just scan a little bit lower or scan a little bit higher. That's a problem. And then there's an overall lack of awareness. So let's talk a little bit about perceptions of risk, right? Because we all have different kinds of perceptions of risk. Like for me, my perception, I bike a lot to work, and so I'm terrified of cars, right? I have a pretty high perception of risk. I had a friend that got hit by a car just on Friday, and they took him to Regional 1. They told him at Regional 1 that they have seen 6 hit-and-run fatalities in Memphis in the last month. 6 hit-and-run fatalities, if I can talk right. That's bad. Like, that's a problem, right? So, but do we really perceive cars as a risk, like versus taking a flight? What we know and what everyone's told us is that it's more risky to drive to the airport than to take the flight to Paris, right? But we all are more nervous about the flight to Paris. So people have different perceptions of risk, and radiation is like case in point number 1 of people who freak out because you're going to tell them they're getting a radiation exposure equivalent to 100 flights to Paris, right? That's why I stopped using the 100 flights to Paris analogy and went back to just, because some people don't want to fly to Paris, they don't like the French, plus they're terrified of planes, right? But we need to recognize that these perceptions of risk are part of what we're up against in terms of educating people. So one thing that is helpful is like to have informational brochures available where the patient can look at risks, right? Now what's ironic to me is I'm terrified of driving, right? But they say that for every 10 minutes you spend on your bike, you've taken 2 years off of your life. That's the risks related to biking. But where is my perception, right? My perception is towards the cars. So this is something we all do all the time, even myself. So the way that I look at it is like, would you rather, right? I'm not quite that flippant with patients, but would you rather find out whether or not you have appendicitis today and we get this appendicitis taken care of, or would you rather leave the hospital without the CT scan knowing that 50 years from now you avoided lymphoma, right? I think I would take, of those two, I would take the find out I have appendicitis and I live today, right? That's kind of the way that I think about it. I don't quite put it to patients quite that crassly, but what you can do is you can ask them questions that kind of lead them down that pathway. Do you want to find out today whether or not you have acute appendicitis? Do you want to get this taken care of, the pain that you're having? Okay? If you're concerned about the cancer, would you rather know that for sure we can treat this today, or do you want to wait 2 weeks? Are you willing to wait those 2 weeks? That's kind of the way that I frame it. But again, you have to start with that benefit versus risk model. You have to start there. There's benefits to this, there's risks to it. So you make the decision, you make the call. It is always the patient's call on anything that we do. And that's not just determining whether or not they want the exam. I give the patient as many choices as I can. Do you want a pillow under your knees? Right? Yes or no? Anytime I can give the patient a choice, I will give it to them. Do you want to go ahead and do you want to change into a gown now, or would you rather wait 10 minutes and change into the gown? Right? You're going to change into the gown at some point, but you have a choice whether you can do it now or later. And then the final point, the point that I always stress at the end, because it's probably the one thing that they will remember among all this gobbledygook, is I am a trained professional and I'm going to do everything I can to keep your dose low. They need that assurance. We can't just assume that they think that we know, or that we're going to do that. So they should be told of the small risk involved. We should restrict the procedure to just those cases that need it. And we need to make every effort to decrease the dose and also communicate that to the patient. I'm doing everything I can to keep your dose as low as possible and still get good pictures. And then shield. That's more debatable. So let's look at some special considerations, and we're rounding towards the end. This is kind of one of the last things that we're going to talk about is the sticky wicket with pediatric CT scans and why there's such a big stink about it. Kids have an increased sensitivity, which we've already talked about. They're going to have a higher effective dose because of this dose geometry, and we can't get away from it. And we're seeing an increased use of CT scanning for kids. Any kid that falls off their high chair is getting a CT of their head, right? Regardless of if we see anything else going on. My dad's a radiologist. I think a lot of us know that. There's been a few times we've been out, the grandkids have been out playing, someone gets bonked on the head, everyone, the antennas go up, what's going on, and we'll just sit there and watch them. And if they're not doing things like puking or unbalanced or like weird things going on with their eyes, like what do they call it, where the pupils are dilated in different ways, there's no reason to take them to the hospital. What you're going to just like risk now exposing them to TB plus the radiation that they're going to have to do the CT scan, just forget about it. The kid's fine. Bones are pretty rubbery when they're babies. So let's look at some of these special considerations then. And I'm not trying to guilt anyone who's had to do a CT scan on their kid or felt like the need to, but let's be realistic and talk about what's actually occurring. Let's look at two scenarios, and both of these are within the technologist's control. What we said is that the CTDI volumetric is arrived at by scanning a phantom over and over and over again and being able to quantify the average dose or the measured dose within that phantom, right? So if the phantom size doesn't change, right, which it doesn't, with these machines, when they're looking at CTDI volumetric, they're just saying this is the average dose for the phantom. Well, what phantom? And what's interesting is, depending on your manufacturer, it might change that phantom model out or not. Like GE, for example, changes the phantom model out if you're scanning at a smaller field of view. It'll go eventually to the smaller phantom size. But you can see in this scenario, there was no adjustment by the technologist for the patient's size, right? They did not adjust the technique. What they got reported was a CTDI volumetric of 20 milligray, which would be the exactly same thing for King Hot Dog over here, right? Even though the kid's like a toothpick and King Hot Dog over here is huge, they're both getting 100 mass, but the CTDI volumetric is reporting the exact same number. I want to stress that it's inaccurately reporting the exact same number, but this is the best that the computer can do. So let's look over here at scenario 2 real quick, just by comparison. Here's an adjustment for patient size. The technologist said, okay, this is a kid, I'm going to scan them at 50 mass, right? Again, the CTDI volumetric will show that. It will indicate that okay, for the phantom at 50 mass, I would expect this decrease, right? Is everyone tracking with me on these two different scenarios? Okay, now let's talk about what really happened. So what did the patient really get, right? Not what the computer told us. But for the same technique, right, the smaller patient is going to absorb more dose for the geometric factors that we just talked about. So in scenario 1, even though the CTDI is the same, the smaller patient's dose is much higher. Much higher. Versus scenario 2, even though the technique was decreased, that smaller patient's dose is now just about equivalent to King Hot Dog's dose. So finally, let's talk about radiation dose to the fetus. And y'all have done a really good job of staying awake. But I know anytime I talk about this with a classroom full of female students that this is like probably the number one boogeyman, right, that we all experience in thinking about working with this stuff. So let's be very honest about how this stuff works and why we ask the questions that we ask. Because as a CT tech, I got very accustomed to saying, hi, my name is Ben, I'm a CT tech, I've been working here for about 10 years or whatever. Is there any chance you could be pregnant? When was your last menstrual period? This is how I meet women all the time, right? You get pretty immune to asking people these kinds of questions. They kind of expect to be asked this kind of question. Why am I asking them about their last menstrual period? It's because of point 1 here. The radiosensitivity of the fetus is greatest in the first 3 months, right? It's greatest in the first 3 months. So I'm thinking, okay, here's when your last period is. I want to be fairly close to that for CT scanning, right? Because the likelihood of there being a viable life close to that last menstrual period is pretty slim. The further away I get from that last menstrual period, the more likely that there could be, for example, a child that's like two weeks old or something increases. And that's when the sensitivity is that like 2 weeks to 3 months. The reality is that prior to that 2-week mark, it's an all or nothing kind of thing. It's an all or nothing kind of thing. So if you're ever concerned, if you're thinking about getting pregnant and you're working in CT, you're working in nuclear medicine, wherever you work, know that that 2-week period is an all or nothing kind of thing. This is what the science is telling us. Now, we continue to research this as best as we can, but the data that we currently have says it's all or nothing. What do I mean? If a person is irradiated in that 2-week window between conception and the 2-week mark, either the thing just breaks off, the pregnancy just terminates itself, or it continues on without any changes whatsoever. Without any changes whatsoever. Okay? So this speaks to the body's tremendous ability to repair itself. Within every single cell of your body, there are complex repair mechanisms that can respond to any kind of DNA damage, right? Not just radiation exposure. The antiperspirant that you use, right? The orange juice that you drink, the insecticide that you sprayed on the mosquitoes, all of those things have LD5030s. They have some lethal dose related to them. And all of those things could impact a fetus. So let's be perfectly honest with our patients. We do things all the time to our little babies that could cause problems, right? Radiation is one among many. So if we're outside of that 2-week window, we're golden. I mean, if we're within that 2-week window, we're golden. Anything beyond that is where things get complicated, because we're going to have to estimate a dose based on a lot of factors that go into that early life. So the risk-benefit ratio of performing a CT scan on a pregnant woman has to be weighed very carefully. Are we going to do CT scans on pregnant people? Yeah, we are. Are we going to weigh it very carefully? Yes, we will. Because the reality is there is a potential for two things, right? Here's the gnarly side of it. The risks, the real risks, are on one side, increased likelihood of mental retardation, right? Increased likelihood of pediatric cancer. Those are the things that we're talking about. I typically don't share that with patients. Am I withholding information from them? No, I'm not. I'm just trying to give them as best a framework for the decision that they have. If they want to press further and they want to know specifically what risks are we talking about, I will talk to them about that, as well as the potential incidence amounts. They're not a sizable increase. They are significant, but they're not big. So fun stuff. So let's talk finally about some strategies for reducing it for pediatric patients and for fetuses. Again, it's a lot like the stuff that we were talking about before. We will adjust mass to the patient's size. Anytime available, we will use automatic tube current modulation, and we will use it appropriately. Every single manufacturer uses ATCM differently. We're going to avoid increasing KVP, because like we said, that can cause a 35 to 40% increase in exposure. We will increase pitch whenever possible. If it will not affect spatial resolution, we will increase pitch, and we will limit the use of thin slices. Those are kind of the right now, five big ones. The other one that's emerging more and more is using iterative reconstruction. But she doesn't talk about in our textbook. It is a strategy for dose reduction. Here's some ones that we might, these are kind of no-brainers, some of these. Limit repeat scans, duh. So here is iterative reconstruction methods. That's still an emerging technology, and it's fairly controversial, but it's more or less been adopted. We're going to verify right off the bat, is the CT recommended? Is there another way that we can do this? Like, for example, there was a debate a little while back about doing CTAs of the chest to rule out pulmonary embolism on pregnant women versus doing a VQ scan, a nuke med exam, which has the higher fetal dose. And I think that CT wound up coming out on top at the end of the day as the safer exam. But there was a lot of debate about it. So it's worth revisiting the literature every now and then. We will customize the exam, shield the patient when it's appropriate. All right, and that's it. I do want to show you something here, because this may help you understand why I rambled on and on for so long about the boredom or the unrest that we have in talking about some of this stuff. According to the American Association of Physicists in Medicine, here's where we are at in terms of radiation safety in CT. We're at the bottom. We haven't really even gotten to level 0 here. So a lot of the facilities and stuff that you're working at, there's a culture, there's resistance to reporting, right? They're not even adjusting CTDIs or even understand what I'm talking about when I talk about adjusting CTDIs. And we have no way of reporting or collecting doses to radiosensitive organs, right? So we are just now stepping out. 2006 was when the big kind of awakening occurred, and we're on a cutting edge right now. As we talk about this stuff, we're on the cutting edge of knowledge about these things. Okay, thank y'all.